Hello, everybody. Thanks for joining us. We're really excited to jump in and get started today. Happy Wednesday. So today's session is going to be about how we talk about treatments like ketamine-assisted psychotherapy and how we educate clients in an ethical way. So I'm very pleased to welcome Sam, one of Journey Clinical's prescribers, and Jay, who is a KAP provider, to present to you all today. One of the biggest barriers to care with KAP is actually not eligibility, but it's language. People can't access a treatment that they don't understand or one that feels mysterious, risky, or medicalized. So in KAP, education is incredibly important. We found this to be the case among our community of clinicians who are offering this, that therapists play a really critical role in helping clients understand what this treatment is and what it is not. But they want to do that in a way that's grounded and ethical and empowering to the clients, and be cautious of not being too directive with sharing about the treatment as well. And so this session is designed to equip you and empower you to have those conversations in a way that feels grounded within your practice. And so we have two speakers today that represent two sides of a collaborative care model in the delivery of ketamine-assisted psychotherapy. So there's medical aspect of the treatment that's covered by a medical professional such as Sam, who is a prescriber and a psychiatric nurse practitioner. And there's the therapeutic side of the treatment, which is covered by a licensed mental health professional such as Jay, who's a licensed professional counselor. So today's session is eligible for 1 hour of continuing education credit. And I'm going to share with you right now and at the end of the session the link to be able to complete the quiz and course evaluation, which helps you earn your certificate. And that will also get sent out to everyone who attended, but just so that you have it, you can check that out now. And I also want to just mention who we have today. So I'm really pleased to be in a Zoom room with you all as opposed to a webinar. We can see each other's faces, which is much more pleasant in my opinion. And we have a really mixed audience. We have some longtime KAP provider, Journey Clinical members, lots of names I recognize. I can see Meredith, I can see Julie, lots of people here. But more coming in every minute. And we also have some therapists here who are considering adding KAP to their practice or just curious to be informed about ketamine-assisted psychotherapy. Maybe they have clients that they might refer to another clinician, or they may be curious about leading that treatment themselves. And so with that, I also wanted to briefly introduce my colleague Tyson, who's here, which if you are a therapist who is not yet practicing KAP in your practice, then Tyson is a great person to speak to and to talk about your practice and consider what if it makes sense for you to integrate this into your practice. So Tyson, I'll let you introduce yourself and I'll put the link in
Yeah.
the chat to be able to book some time with him.
Yeah, thanks, Lizzie. As Lizzie said, my name is Tyson Ford. I've been with Journey Clinical now for about 4 years. I've had the pleasure of helping well over 2,000 therapists personally kind of get started on this journey. And with this comes a lot of questions, concerns, just general, how does this work? And so that's kind of what I do. And I notice, like Lizzie, some of the people on this call I've definitely met with before, and I do look forward to meeting with anybody that I have not met with on this call. So thank you.
Wonderful, Tyson. Thank you. And I put the link in the chat so that you can book some time with him. We'll send that out as well. And I always forget to introduce myself every time I do this. So my name is Lizzie. I help run Journey Clinical's community of therapists and our education program. So working with wonderful therapists and medical team members to help spread education among our community and through our community out into the world so that more people can be educated and informed about treatments, psychedelic assisted psychotherapy, legal treatments such as ketamine assisted psychotherapy. So we host a lot of programming. We're really excited to have you here today, and we're excited to host lots more to come. And that's what I'm here to help with. Chloe, you asked if we need to check in for the CEU credit. Your attendance in the Zoom is your check-in. So we have your name down here. And we'll be sending out to all of your emails that link. But again, I put the link, the first link in the chat is a link to access the quiz and course evaluation so that you can earn your certificate. Um, And then, without further ado, I'm going to introduce our speakers today. So, we have two incredible clinicians. Again, they represent this collaborative care model. So, we have Jay, who is a licensed professional clinical counselor based in Columbus, Ohio. And I'll let you introduce yourself, Jay, rather than me chatting.
Yeah, thank you. So I'm a practice owner as well as KAP psychotherapist and LPCCS, and I work with individuals, couples, as well as groups with KAP. Primarily focus on individuals working through life transitions as well as trauma and trauma-related disorders. So a lot of PTSD, complex PTSD, attachment, developmental trauma, those types of things. And yeah, really excited to be here to talk about KAP with you.
Wonderful. And Sam, you can go ahead as well.
Hi, my name is Sam. I am a psychiatric nurse practitioner. I'm also certified in primary care. My background is really in substance use disorders and trauma treatment. I work at a residential center as well, and I also provide outpatient CAP services. And really happy to be here. Journey Clinical has been a wonderful resource for many people that I've worked with over the time I've been here.
Wonderful. Thank you so much. So we're going to jump into some of our discussion today. So the first, we want to set a foundation of what CAP is and what CAP isn't. And what we're talking about here is we're going to share information about CAP, but we're also sharing it through the lens of how we might talk about and share these things to clients, or in Sam's case, would be considered a patient. So, Sam, to ground us, could you talk a little bit about what ketamine is and why it's being used in mental health? And as you explain this, I'd love you to model the kind of language that you use with a patient in an intake session.
Yeah, absolutely. So I'll kind of give my little ketamine spiel that I use with patients, very similar language to how I describe it in this context, but just so you have that overview. So I typically start with by explaining, ketamine is actually a dissociative anesthetic. It's not a psychedelic, just to clarify that piece. But it has psychedelic-like properties. It has the neuroplastic effects. There can be distortion of senses. People can have visual experiences. And so it falls into this category of psychedelic assisted psychotherapy. It's been around for quite some time now, first synthesized in the 60s. It's used every day in many different contexts, medical contexts for its anesthetic properties. Kind of one of the first uses of ketamine was actually for soldiers in the Vietnam War who needed to have procedures out in the field where there wasn't the ability to be monitored. So what's really nice about ketamine is it's generally very safe when used appropriately. So it actually opens the airways and increases heart rate and blood pressure, whereas other anesthetics might do the opposite, requiring close monitoring. So these soldiers who required procedures shortly after being in a traumatic event such as war, something that they were discovering was that these soldiers were less likely to develop PTSD after receiving ketamine from a traumatic event. This is one thing that sparked this conversation about how ketamine can be used in mental health. There's tons of research. Most of the majority of research is started with depression and treatment-resistant depression, but we've started to see more research popping up, with anxiety, PTSD, eating disorders, many different mental health diagnoses. Um, and so we're learning that this can be used, for many different issues that clients are kind of working through. In this context, we're using it as a clinical tool, a clinical treatment to treat a mental health disorder or symptoms. Definitely different than the recreational model or not model, recreational use of psychedelics. So very different context. And I think we'll kind of come back to that piece a little bit later. And so the other way that I really explain it to patients is the context of how it's used in the medical model, where there's not therapy attached to it. This is the infusion model, the Spravato model, which is great for some. This context, we're using it with the integration with a therapist. And so I'll typically talk about the neuroplastic effects, kind of how ketamine works in the brain. essentially what we know thus far is that the neurons in our brains will actually start to grow these little branches called dendrites. And those dendrites have the capacity to connect one neuron to another. And so within that capacity, we as the clinicians and you guys as the therapists are able to help our patients to kind of make that dendritic growth a little more specific because it's happening, but the integration is how we really solidify and allow this treatment to kind of help people in the long term. So I always say integration is actually the rest of your life. So how do we utilize this treatment to improve what you're looking to improve for the long term, not just for a short term period?
Thank you so much, Sam. So it sounds like there's a good deal of psychoeducation that happens during those intake evaluation sessions. I'm curious also, what are some of the biggest misconceptions or most common misconceptions that patients come into those intake sessions with?
So a lot of times what I'll hear is kind of this expectation that this is going to fix somebody or that this is a cure or it's the magic pill. And as we know, there really is no magic pill. And so it's kind of just talking with the patients about their expectations. Everyone's going to have them, even if subconscious. And so just exploring the expectations with them. And some of the other kind of misconceptions will be that, ketamine doesn't work for them, or what if it doesn't work for me? And so it's less about saying it is or isn't going to work and more about processing those feelings and where is that really coming from? Is there another treatment that hasn't worked for them in the past that's kind of guiding this belief pattern that this might not work for them or isn't working? And so we can kind of process that. There's also misconceptions about the different models of KAP. Like I mentioned earlier, there's the medical model, which is like the infusion clinics, the Spravato model. Or there's plenty of at-home ketamine treatments kind of popping up. I think I get Instagram notifications daily about these different companies that are offering people to take ketamine at home. And really, the big difference is our model is the collaborative care model with your therapist, or if you're new to us and are needing a therapist, we'll help you get one. Um, but just really the model of having the preparation, the dosing session with the therapist, either in the room with you, or virtually, or kind of checking in before and after, and then continuing the integration therapy after. Um, Here's the piece about kind of addiction. So sometimes I get this question actually quite a bit. Is ketamine addictive? What if I become addicted to this? And really the risk of addiction in using ketamine in this context is very, very low. I've never seen it happen. I'm not saying it doesn't exist. Even I actually worked at an infusion clinic for a brief period of time. I didn't really see people like becoming addicted to ketamine even after that context. So yes, there is addiction potential with ketamine. Where that comes from is this recreational use. It's typically daily, regular use, and ketamine is actually not physically addicting, it's psychologically addicting. Similar to cocaine. And so again, the risk in using it in this way is extremely low. And so I just kind of review that with them and let them know that the likelihood is very low. But it's an important question, especially if addiction runs in their family or if they have a history of addiction. Um, and so a lot of what my job is just to slow things down, make sure that expectations are realistic, and truly ethical care means not treating desperation as a reason to move faster. So when people come to me and say, like, this has to work, this is the only thing, it's how do we slow that down, process it, and engage with the therapist as well to really create realistic expectations.
Thanks, Sam. And I am curious about patients who come in with a sense of desperation. How is that also protected for within the protocols that you follow for CAP, um, and making sure that somebody is complying with those protocols?
Yes, absolutely. So we do, a screening process. So that initial evaluation with myself is a 60-minute process. Um, where we do a psychiatric evaluation. There's obviously time to talk about ketamine and prescription and all of that, but there's a good chunk of time where we're really diving deep with the client or patient to understand, why they're seeking this treatment, what's their history. We look for drug-seeking behavior. I mean, again, the risk is probably lower that someone's coming to this type of model as a drug, for drug seeking. There's a lot of steps to get the ketamine. We only send a small amount that first time. So that's, again, less likely, but not impossible. So we, of course, look for that. I also ask them, like, why do you want to do this treatment? What's your reason for coming to this? And a lot of times I'll hear, oh, my therapist recommended it or a friend recommended it. And so it's kind of like diving deep, like, what do you already know? How can I fully educate you based on kind of what you already know? And is this something that you actually want for yourself? And it's not just something that someone is telling you to do. And if they're not sure, that's where we talk about it. Gather what they know and again, process kind of where they're at and what do they need to know to feel more comfortable. We also make sure that clients have integration support. So that is a required part of our program. You have to engage in the preparation and integration. It's really, really key in this model. And so if someone's not willing to do the integration process, we wouldn't be the right model for them. And so that's where we would, if someone's coming in new without a therapist, we would assist them in matching with a therapist. So again, integration required, it's not optional. And then non-adherence is a safety issue. So if for whatever reason someone is, misusing their medication, it would be a reason to potentially stop treatment. And so we also look for those pieces. So if someone isn't willing to or able to participate in the integration, it's a vigilance issue. And ethically, we wouldn't be able to continue treatment.
Great. Thank you. So there's this model of the psychotherapy around the medical aspect of the treatment as well. And so I'm curious also what is the conversation looking like on the therapist side? So we're going to hear a little bit from Jay. And also I want to name that how do we handle the fact that KAP can create some pretty life-changing outcomes for people. And so we don't want to create a false sense of expectation. However, 87% of Journey Clinical's patients who go through the 6 to 8 session protocol do see a reduction of their symptoms, which are measured from clinical scales, PHQ-9, GAD-7, and SDS scores. So we hear stories from therapists whose clients their lives can be dramatically changed. So how do you balance when this is a treatment that could potentially really benefit your client? How do you approach that conversation with them in a balanced and neutral way? So I want to sort of plant that seed as we turn it over to Jay and hear. First of all, Jay, do you have any kind of commentary on what's been shared thus far, or specifically to this question of
I
outcomes?
was taking some notes here just as Sam was sharing, and a few things come up, but I really want to emphasize that element of integration and the importance of that. And I think of, even before you're getting to that medical intake, making sure that we stabilize before we catalyze. And I do really think of the KAP work and a lot of the depth-oriented work in which I engage in with clients, that we really want to have that stability in place before we're catalyzing. And so one way to think of it that I was thinking through that might be helpful is this idea of a plane and the dual wings. And one is the medical provider, the other wing is us as the psychotherapist. And if you think about ketamine, then it's kind of like the fuel for the engine, and that's going to get you off the ground, certainly. However, if you want to stay flying, it really takes then that support, both biologically, medically, as well as psychologically and psychotherapeutically. And so those dual wings are really important. And so I think that's one of the differences even between KAP and, say, a medical model. It doesn't mean that support isn't there. I would say that in order for that treatment to work, that support has to come from somewhere. That could be resources like family, whatever. But in this model, it's really the therapist that is there that's really providing that support. And that is the integration then is not only flying that plane, but also being able to land that safely. And so that I think is as I was thinking through it, a helpful way maybe to think about this. But that stability piece is really important. So those are my thoughts, just as I've been listening to this.
Thank you, Jay. And absolutely, I think it's worth just re-mentioning that as we talk about this collaborative care model, just to re-mention that ketamine-assisted psychotherapy, sort of gold standard treatment model of this, consists of preparation, dosing, and integration sessions. All of these are supported by a licensed mental health professional within this context. So preparation integration sessions might look similar to a regular therapy session. The dosing session is where the ketamine is taken during, and also combines preparation and integration within that session itself, plus the journey. And the medical support is happening in the intake evaluation and follow-up appointments, which are separate from those prep, dosing, and integration cycles, just for anyone who wasn't aware of what that model looks like. So I want to ask you to, Jay, talk a little bit about how you introduced KAP to clients. So this is technically kind of a step before they would come to that medical intake where they were referred by you to someone like Sam for that medical evaluation. So how do you broach the topic? How do you mention that this is something in your practice? If you could share what those conversations look like, it would be great.
Yeah, and so that's of course going to vary depending on why a client's showing up and that context. If it's a client that I've been working with for a long time and I have that history, or it may be somebody seeking me out specifically for, the KAP treatment and that modality. But I really think of like the value maybe that I take, and I think of it as kind of my stance, is one of humility. In having these initial conversations, and then two, really thinking of this in terms of expanding the client's options without steering their choice. So use an example of like if you go to a restaurant, very often there's a question that you may ask somebody that's serving you of like, hey, what's the best thing on the menu? And what you might get back is a response such as, well, most people find that this is, most people really like this. And what that does is it really allows for that freedom in the agency while still expanding the menu, the options that are there, and providing some of the information. So I really think of it like that humility piece is so important, because I don't know the answer to is this going to be an appropriate is this the right choice for that client, because I'm not in their shoes, and I joke with clients that advice is cheap because I don't have to live with the consequences of that. I'm not weighing all that you're weighing, and so really kind of handing that choice and agency back to them. I think that's the humility piece of it. But how I bring it up is really talking about it in terms of a collaborative treatment, talking through how the ketamine can really act as a catalyst to help support the therapeutic process. And I even think of integration, that work is what we do in all therapy, which is about supporting our clients to become whole. And integrating rather than and integrating parts of them maybe that they're disconnected from, and so that idea of integration, I really do see ketamine as a tool to help support that, so it can open the door. The client's still going to have to walk through. So really talking about it in terms of that, some of the benefits as well of neuroplasticity, and really the idea of neuroplasticity is those connections that there's an opportunity for in that open window of critical learning. It depends on whether that's adaptive or helpful. And so that's really where the therapy and the integration piece is so crucial. So I really talk about it, very much like I would if it was EMDR or any other modality, and putting it out there in terms of one option among many, and making sure that we're talking through all of those different options. And in a way, the ask, tell, ask model is one that I like to bring into these conversations to really find out, well, what do you know about KAP? What do you know about ketamine? Then I can kind of fill in some of the blanks, and then inquire as well as we follow. So it's really kind of being there to facilitate and lead that conversation and provide a perspective. But I really think of it as they're the expert on their life, even if I may be more of an expert on the modality that I'm speaking to.
Trying to teach myself how to do coding.
I think somebody
One
else
second, let me make sure someone's
maybe
muted.
mute. Yeah.
There we
Thank
go.
you.
Well, thank you so much, Jay. And you have so many helpful little snackable phrases that you use. So I really appreciate you sharing those. And one piece that I wanted to sort of kind of role play with you how you would handle this is, clients who might ask, you really lean in and ask you for your opinion. Like if you were me, would you do KAP? And maybe you can touch a little bit on whether you self-disclose in some cases about your own experience with the treatment as well?
Yeah, it's such a wonderful question, and I'll answer actually the last part first. So I do self-disclose, and that may be a little bit different than in some other modalities. However, I'm very clear that any of the modalities I work in, so I'm trained in EMDR therapy, IFS, I've experienced those as a client as well. I think that's an important aspect of engaging um, in therapy. And so I'm very clear, that I have experience in this, and that it's part of why my own personal experience and my own personal journey is to become a therapist is a part of how I'm showing up. And so I think that can be important. I think it can be helpful as well for them to understand that, I have a stake in it as well. But I really think about um, the, the, when somebody is asking that question, it really is being that mirror. I'm not going to answer that for them. And I really go back to the humility piece because I don't have the answer for them, but I can help them get to that answer. And so, I'll start by really normalizing, that ambivalence, and that's an understandable thing as you're exploring something where you may be hearing this, some of the hype in the media. You might be hearing some of the stigma as well that's there culturally around this. So there's so much to engage with. So the questions really that I would respond with are, let's explore, what would that bring up if I said yes? And on the other side, what would that bring up if I said no? What are some of the fears that are associated with that? And so those two questions I think are wonderful and kind of opening it up. And then the question that is really fun to ask after you've got a lot of that stuff on the table is what was the answer you're most hoping for hearing from me? And I think of it like you're off to the races in the conversation at that point of really getting to understand the client's perspective rather than displacing that responsibility that is the client's.
I love the clap reaction we got here. Feel free to react, everyone. It's so much fun on Zoom to remember that we're all here together. So thank you, Jay. That's really, really insightful. Another topic I want to bring up is sort of we framed this session as client education, and yet a really big part of doing this work and also expanding and gaining more clients in your caseload is educating other colleagues about what this treatment is. A lot of therapists get referrals to their practice from other therapists who have clients who are seeking a provider who's trained and can support them with KAP. So my question for you, Jay, and if you have any thoughts on this as well, Sam, is how do you talk about KAP differently with colleagues versus clients?
Yeah. Very, very different, but I'd say at the core, it's the same thing. It's just more meeting our audience, where they're at, and so you got a lot more that you can work with very often in a common vernacular with colleagues. So really, bringing in some of that clinical precision. Maybe we're talking about default mode network downregulation, neuroplasticity, some of these things that they may or may not know. And again, you get an opportunity to really open up around discussion there, but really looking at it, I think from more of the, when it's an individual client, that's really the art of therapy, and it's more of the science of therapy than when I'm talking to a colleague, because we can talk about an aggregate, what the scientific research is, what all of those mechanisms of actions might be. But I think of it, when I'm talking with clients, I'm using a lot more metaphors. So rather than neuroplasticity, maybe I'm talking about shaking that snow globe to explain the subjective experience, and doing so without some of the same language that I would use with clinicians. But I think that the biggest difference is probably focusing on the container and that felt sense of what's happening in the therapeutic alliance when I'm talking to a client, whereas I'm looking at more of the structural pieces or the protocol as I'm having conversations then with clinicians.
Wonderful, thank you. So we framed the conversation about this collaborative care model that we're like live looking at with you two both in the room today. I think Sam, I think you're licensed in Ohio, right? So
Yeah.
you might actually collaborate on treatment plans, which is cool. So just to kind of reiterate about the therapist's role within that collaborative care model, Jay, and how you explain your relationship to a prescriber like Sam to a client, and what is in your lane versus Sam's lane.
Yeah, and we have had the opportunity of collaborating on care, and it's been a beautiful collaborative experience in working with Sam. So it's exciting to be able to be here with her. So I really think of that scope and that scope having those clear lines that we understand, and then that the client understands is so important as far as trust for the overall system. And so as a psychotherapist, I own the preparation, psychological support, and what happens during the journey experience and the integration piece, and the prescriber that you're partnering with, really that medical assessment, dosing, safety monitoring, and the medicine components. And that delineation is so important then as far as having trust. And I really think about it, when I'm staying in my lane, clients, it really allows them to feel safer, and as well that there's support beyond just me, and it's a wonderful thing. And so those lines, that's really how I talk about it. This is my core function. I'm here to help you prepare, psychological support throughout the process and integration.
Yeah, and just to echo that, I really try to, whenever I have patients, asking about kind of the differences and just really owning, like, if you have any medical questions, don't hesitate to reach out to me. Don't hesitate to let your therapist know, and your therapist can reach out to me because I really want to make it feel like there's this delineation. And I also look at my sessions with the client or patient as part of preparation because I'm preparing them medically for the whole experience. Here's how you're going to take your vitals. Here's how you're going to eat that day. Here's what you're going to do with liquids and how to take the medicine. Like, that's feeling really prepared in how to approach it from the medical side as the client or patient. That plays a huge role too because they get into the session, they're like, I forgot everything. And usually their therapist has some of that information. They can kind of reinforce it as well. But having that foundation, I think, plays a really big role too.
Yeah, and that leads me into my next question I see, which is about all of this education that kind of happens continually and throughout the process. How have you seen that change outcomes? Clients who are more or less educated, how does that affect their actual treatment plan and experience, that level of education they go in with?
Hmm. I
Either
definitely
either of you can answer.
Yeah, I think that I mean, it plays such a big role, especially I think what I see happen is when somebody kind of comes in having no prior knowledge or very minimal knowledge, and being able to like explain it to them. And like Jay said, I'll often use metaphors. I'll share one with you that you guys might like. It's similar to the snow globe. I actually took it from Lizzie, but took it to the next level. So the way I kind of like to explain the neuroplasticity piece is like if we think about, you know, childhood trauma, kind of complex PTSD, all these things that happen, we develop our protective mechanisms. These pathways are ingrained into the brain, and how do we try to start thinking differently? So ketamine, if we think about like a ski hill, and so on the ski hill, everyone takes the same run. There's the blue run, the green run, the black diamond, and these are these pathways that have been reinforced that might look like depression, anxiety, PTSD. Ketamine is the fresh bed of snow that gets laid onto the ski hill, and the ski hill's your brain. And now those pathways are still ingrained underneath the snow. They still exist, but the ketamine allows us to look at a different pathway. Okay, I'm going to take this other run. Now you take that once, great, but now you can start to reinforce it, and that's where the integration piece comes in. How do we reinforce these new pathways that we've now created, knowing these other ones are still here, but we want to start taking this other pathway instead. And kind of once you give them the full breadth of education, they actually get really excited to engage in the prospect of this being helpful for their mental health. So I definitely see a big shift once I go through the educational piece of our session, and typically patients leave feeling feeling more comfortable. They know how to take the medicine, they know how it's coming, and that plays a big piece in helping them feel safe and comfortable moving forward, which also allows them to feel more safe in the context with the therapist because they know all the medical pieces are taken care of and they can allow their system to go a little bit deeper.
I'd really love to build on that, Sam, and that one of the things that the education piece really helps support for clients showing up. Well, first off, like who actually shows up. I think it's a helpful thing to really have that information so that somebody can actually opt out. And in other words, to come to that no quicker is a wonderful tool. And as well for those who really have confidence in the yes if they're moving forward as well. But I think of it that like that safety piece is so important, and we often think of that as resistance, not just towards the treatment overall, but the experience itself of the non-ordinary state. That I think of it less in terms of like resistance, and it's sometimes more helpful to think of it in terms of that safety and education, and that understanding piece is so important for establishing a sense of safety. And so what that may mean is not eliminating fears out of the knowledge and what that understanding is, but instead it's about being resourced and actually having the ability to hold and bring along that fear and for that to be okay and not disrupt. And so, in other words, to really have a deeper surrender, even though that fear is there to the overall experience.
Wonderful. Thank you both on that topic as well. And I wanted to make sure that we cover some of the questions that were some were submitted during the call, but I also was checking out in people's registration data some topics and intentions that people had coming into this call. And this is a big topic to talk about and think about, but there's a couple questions about, and it was mentioned today about addressing stigma and addressing some of those misconceptions and myths and misinformation that's out there about KAP. And that's a big part of course, the psychoeducation piece. And it's a topic that I think prevents a lot of clinicians from having this conversation out of fear of what if this comes up and I don't know how to handle it. So if either of you could mention, experiences that you've had, maybe where these topics have come up, what types of maybe language you have in your back pocket to address some of those pieces, or what types of conversations ensue to address some of those more challenging conversations, that would be really helpful.
Yeah, are you kind of talking about the what to say and not to say questions, Lizzie?
Yeah, I mean, you whatever that brings up for you, but yeah, specifically, I mean, you had mentioned, there's hype in, or maybe it was Jay, but there's hype in the media, but there's also some fear out there about this type of treatment. And so even just examples of questions that you've received in the past and how you were able to broach those topics or maybe direct people to other resources as well.
Yeah, so I think I get the question a lot, like, what if it doesn't work? What happens next? And of course, the reality is we have no way to know what's going to work and what's not. But what I really do is I try to equip my patients with as much information and tools. Sometimes it might be information overload. But I try to really equip them just with everything that they might need. So again, if the question about addiction comes up, I'll kind of go through all the possibilities. And it's not saying like, hey, there's no possibility that somebody could become addicted to ketamine. The reality is that's not true. So being truthful and honest and also being realistic. Okay, here's the reality of this happening, and it's actually pretty low. And yeah, when people are like, this is the only thing, this is my last hope, I'll try to explore what have you done? What have you already tried? And if they're like, this is the first thing I'm trying, it's like, okay, there's actually a lot of hope then, because we have a lot of different tools that we can integrate into this. And for some people, maybe the cost is a barrier. And so if somebody feels like this is their only hope, it's like, okay, well, what other maybe covered options can we integrate into our therapeutic alliance and things that you can utilize before we maybe come to this. So it's looking at what are all the options, what has already been tried, and just processing those feelings that they might have about things they have or haven't tried yet.
And I'm seeing some great questions too in the chat that I'll try to kind of hit on building, on the conversation here. One of the things that I've heard, well, isn't this just getting high? So you've got that. You've got, well, isn't this street drug? And I think of it as kind of leading with the ugly is helpful in kind of normalizing all of this. And so, horse tranquilizer, I might throw that out there. Yeah, you probably heard this, and so we can start to then get into a conversation then about what's the difference between a medicine and a drug. And so there can be a lot of conversation there of really, getting to what ultimately is usually the fear that's behind that. And that fear, I want to validate because culturally, like these are this is the, I think of the discourse, right, culturally that we're also reconciling and reckoning with. But one way to think of it too is that like we have many molecules, including water and oxygen, that used in the wrong dosage in the wrong context can kill us. Yet we also need those to survive. Not the same as far as ketamine. We don't need that in order to stay alive. However, like that idea of limits and context really allows us to talk about the clinical scaffolding that's in place. And generally, like even when it comes to concerns around bladder issues and some of those things, most of that, not all of it, but most of that, it happens when we're talking really high dose, more in a recreational use. And I've actually steered away from using recreational use to non-prescribed use to really, hone in on this difference between medicine and drug. And that in the clinical context, that's part of why we've got this support and there's the integration and all of those other pieces that are part of the clinical scaffolding to really look at any of those risks. If there was any, issues or concerns, we're going to be talking about that throughout the entire process before it moves to something that's going to be critically concerning. And as well, like, I'll use an example like bladder concerns. That's one where I think it's a wonderful time for us to, this is how I might talk to a client. This might be a wonderful time for us to come up with some of our questions that we can share with our prescriber and open up a dialogue around some of these concerns. And so I guess I'll get my little bit in here about, that's a great opportunity to open that dialogue and as well, create some of that collaboration around these questions and concerns that come up.
Super useful redirect language. Thank you, Jay, on that one. I want to back us up to a question from the chat from earlier from Meredith, who asked about how do you deal with a client asking, what is it like? What does it feel like? And I sent in the thread with Meredith, we had a little sort of debate about this in the Journey Clinical member forum. I put the link in there for any members who want to check that conversation out because we had some varying takes there. But curious how you handle that conversation, Jay, or did people ask you that, Sam? And how do you share?
Yeah, I'll just share briefly. I actually get that question quite a bit. And really the way I'll explain it is it tends to be different for everybody, but kind of an overview is for some people it can feel like you're floating, for others it can feel like you're sinking in. There will be some sensory perception changes. Typically, your hearing is going to be heightened, so the music will play a role, or whatever is playing in the background will play a role in how the experience gets carried for you. One thing that I really try to clarify is the visual potential of the experience. So a lot of people want the visual experience because that, for whatever reason, feels exciting or it's just something that they want to experience. And so being realistic that not everybody is going to have visuals with their eyes closed. Certainly, if you pop the eye shades off, the room might look kind of funny, but like having imagery is not a standard. And so normalizing having a more somatic experience, having a really emotional experience. And so I might say you might find yourself kind of crying throughout the experience, and it might feel more like an emotional release or like something is moving through your nervous system, through your body. And just really validating that a visual experience does not mean this is or isn't working for somebody.
Yeah, and I speak similarly as far as that subjective experience, but I think even calling out, thank you, the visual experience, it's a great example. So I have aphantasia. What that means is I don't actually see images in my, my mind. And so that's not part of my experience, hasn't been part of my experience with ketamine. And so I think this is a helpful reminder that even if you have, and I would encourage that, your own personal experiences, that's not going to dictate what their experience is going to be like. And so I kind of joke that, I could certainly tell you what it's been like for me, and I'm pretty sure, like close to 100% sure that it's going to be something different than whatever I'm telling you in this moment, because even across sessions, even with all the variables consistent, fasting, etc., it can be wildly different experiences. Ketamine's a little bit of a chameleon as far as that subjective experience. So going back to the in general type of approach that Sam was offering here, I think is a helpful way of putting it could be this, it could be that, and as well, it could really feel like not much of anything. There are clients that experience that as well, and so it's really about normalizing the possibilities than more than saying it's going to be like this or this.
I think that's really, really helpful. And then inviting curiosity is such a theme in all of this. So appreciate that perspective. There's so many questions in the chat. I don't know if Jay and Sam, you can also read those and if, feel free to jump in on any of the questions. I'm sort of catching up a little bit. We had a little bit of conversation. I mean, you were obviously emphasizing the importance of integration. Um, and we also mentioned that if a patient weren't to commit to doing integration work, they would not be eligible to continue with treatment. Um, what does that look like when working with a client to really emphasize the importance of that, versus the outcomes coming from the effects of the ketamine themselves? What does that conversation look like? Have you ever dealt with a client, Jay, who was less motivated to continue the sort of integration process, or what does it look like to have the conversation up front that sort of ensures that they're committed to what that looks like?
Yeah, I have had certain clients where that integration piece w was a bit of a challenge, and as well, like having conversations as well about that's not the right fit. And so, I even had client relationships, in that work terminating because of that lack of interest in the integration. And I think of it like from like less of a stepping back from any judgment that I might have about that. I mean, I do, and I think of this as more the discernment work. Like CAP, I see as crucially important, not just for the experience of a shift or a change, but for sustaining that change. And without that therapy piece, it's a different thing. And there are other ways to, if that's what you're interested in, like ketamine clinics, IV, like maybe that route of administration is more appropriate. But as well, like it's more a matter of figuring out, whether that fit is there or that match is there. And so I think that's really part of the education piece. But I really frame it in terms of, and I've started to think about it more in terms of like, no, like in general, what somebody's signing up for. And I really think of it in terms of either 2 sessions or 6 sessions. Two is kind of like a catalyst work. They're going to have the first, which is the handshake dose, and the second experience where, you can kind of get into that work and use that as a disruptor. And then 6 is more for that depth work. But those protocols are there because it is signing up to that overall treatment, of which all of this is an important part. It isn't just about the subjective experience. And what I find as well, though, is that the clients tend to opt out of therapy. Like they're gonna find it other ways if that's what they're seeking, because of the investment of time, because this is hard work, because it costs the money that it costs to have a therapist there. There's certainly other ways of, if that's what they're interested in. So it's still something that we deal with, but I think there's some self-selection as well in that filtering. So as much of that work we can do upfront, it helps prevent some of those conversations after the fact.
Thank you, Jay. And we have more questions flowing in. So this is interesting about how to handle questions from clients who have experienced Spravato when asking about some differences they can expect from sublingual.
That's a really good question. Kind of the way I'll describe the differences is this like Spravato is a model. So it's typically dosing twice a week for a month, and then it's typically dosing once a week, and then some patients can drop down to every other week. So again, I really just highlight the differences in the models. You're going into a room, the medical provider or nurse or whoever is administering the ketamine nasal spray. You're left in the room. They might check on you for a few times, and then you kind of go home. And again, the integration is really up to the person. There's not that integrated support with a therapist. And like the differences, I don't have any like subjective way to tell you the difference between how it will feel. Um, and some people will say that they feel like Spravato doesn't necessarily get them as far. Again, it's very subjective. That's not backed by like a research model. But when I get that question, I kind of highlight the differences in the model with the rapid dissolving tablets or the sublingual ketamine in the way that we use it here. Again, you're having that deeper integration process and support from the therapist. So both are good. They're just different. I hope that answered that question.
Thank you. There's also a question
Can I add
about,
one more thing to that?
please.
Like, I really think of like the that medical monitoring and sitting in a room, often alone, often without music, without obviously that emotional support and psychological support. That's all part of we talk a lot about set and setting. I mean, that's literally it affects both that mindset as well as the context and setting. And so, I think of it, sure, the protocol is like what is the key differentiator, but that set and setting, we know how important that is actually to what the experience is as well that's happening. And so I just wanted to call that out that set and settings wildly different in some ways, even though the molecules are very similar. Well, I mean, the S-ketamine is part of the racemic ketamine that we use in KAP.
Thank you. Jay, do you do any couples work?
I
Somebody
do
asked.
couples work. It's been limited as far as doing CAP work with couples. It's one of my things for 2026 that I really want to dive into because at that lower psycholytic dose, it can be very heart opening. And I think of it, from kind of an IFS frame of really bringing down some of the rigid protectors. They're still there, so that you have just a different space to work with in the relational space. And what often gets in the way of relational work is that when protection comes in, I think of it like we often move out of the prefrontal cortex where that relational work can happen, and so it can be such a helpful tool in supporting that. So yeah, no, it's. I think the story for that is still more of a challenge. I think most people aren't even aware that that is a tool that is available. And so I think that goes back to, even the point of these conversations, that client education piece is crucially important, just so that there's awareness of this, so that you can find those that are interested and might be a good fit.
Absolutely. And I think this will probably be the last question we address, perhaps. And it's a really rich and really important question. And I think we'll kind of answer a version of it today. So the full question is, I've worked with clients with sexual trauma using EMDR and found very rarely that once we get into the trauma that we opened up a lot more than what was initially anticipated. And this can be managed in session or by going back to resourcing and preparation. Have you ever run into this with KAP? And how is this managed if there is, say, an abreaction during or after the dosing session, despite preparing the client ahead of time? And the larger question that's a frequently asked question, and frequently a very important topic to discuss with clients is this question of what if I get worse before I get better, or that is a possibility. And so to really simplify this really juicy, thoughtful question, I wonder if you two could address that because it can happen for clients, and it's something an outcome that should be discussed.
Yeah, and what really struck me even about the question is referring to that as abreaction. And I would say that's more of a reaction that often can happen. In other words, like we're opening up to that possibility when we start to do this type of work. And so I think of it that's really crucially important then that that resourcing is there and that foundation is something that you're working with from the very start. What I also find is that it requires and required of me, a lot of consultation and guidance as well as I was working with my window of tolerance. I like to think of it, we've got my window of tolerance as well as my clients, and very often it's less about the client and more about my own window of tolerance for client's response and what might come up. And so as I've gotten more comfort with what comes up in session and the capability to work through that and integration, I've got a different level of tolerance for what I would refer to as kind of out of the ordinary. And so I think of it less in terms of that's something wrong and more that that's actually a part of what we're engaging with. And if that can be met with a different experience, even that somebody's had, that's so much about the memory reconsolidation piece and trauma work and healing that is a part of it. And so I keep in mind that the idea that like what makes something trauma isn't just the event that happens, including what happens in a journey experience. It's whether or not you have the resources to actually support processing that after the fact. And so that's where, really the integration piece I see is almost more important than necessarily what happens there. Obviously, providing support, stabilization, and resourcing. But I really would go back to, working with a client to figure out what that resourcing is so that they've got the intrinsic resources available to work with what comes up. And that's really, if that's there can be a lot more that you can work through. So I know this is very nuanced. I'm just trying to get through this quickly, but I certainly welcome, more dialogue around this because it's really important.
Yeah, and I'll just share that, that's something I don't bring it up in every intake, but especially if I have someone with PTSD and trauma, I look at that as an informed consent piece. Like there is this reality that what comes up might be difficult. And when we say getting worse or better, like, yes, you might get worse. And I put that in quotes because that just might mean that things are more opened up and we hear of like the vulnerability hangover term, like too much kind of happened, you're outside of your window and things kind of snap back down, which is where I really, really love this model because that's where the therapist kind of can come in and support you through that. So just making sure that you have the time capacity to support someone if they are destabilizing a little bit. For example, I use ketamine, use KAP in a residential setting with trauma survivors, and we introduce it later in the treatment, and we ensure that the client is with us for a certain number of time because if what comes up is really difficult and it takes more time to process it, we want to make sure we have that time and availability to help them kind of restabilize and using the tools that Jay was mentioning, the resourcing, regaining some of that because it's real. I mean, and to self-disclose, like I've had it happen to me and it was really, really difficult. And my therapist, thank God I had her, she played a huge role in helping me kind of understand what happened, why it happened that way. I mean, I came up with the why, but she helped me get there. And it actually helped me do the getting worse. And then I did really have some significant improvement, but it took some time. And so just always remembering you can slow the process down, just processing what they're experiencing and creating a little bit more space if it does get harder.
Slow is fast. Absolutely. Like, yeah.
Well, that's a really significant way to end the conversation today and just to ground us all in that wisdom, especially with navigating these conversations, to take it slow. And and that's really an important message here. So such an active chat, so much going on, and so many incredible thoughts and interactions going on. And it's great to see again a lot of our experienced member clinicians and also people who are just venturing into exploring this. We had some people asking about things like protocols and pricing, and of course, there's so much information about all of um, that it we didn't talk about today. Of course, there's a lot of different educational modules and resources available, whether you're exploring KAP or whether you're a part of our community. So depending on what your questions are and what you need, be in communication with us. We have so many resources and we want to give them to you. We obviously can't cover everything in a session like this. So I'm going to put my email address in here. I'm also pasting again both the link to do the quiz and course evaluation and earn your CE credit, and also the link to book time with Tyson. That's for therapists who are considering KAP or adding it to their practice. I'm also adding my email address in there. Again, if you have a question, we have a Foundations of KAP course. If you really want the nitty-gritty basic KAP education, we have a lot more advanced content and training as well. We host weekly medical Q&As, which are great for medical questions. We have a great member forum where if you have a question that you want to pick an experienced therapist brain like Jay's on, you can post it in that forum and people will really hop into that comment section and offer thoughts. And a lot of people are using that forum to then, take it offline and have Zooms or meet up even in person. In-person community is also a really big, special part of this community of therapists. So there's a lot to get involved with. Depending on what stage you're in. And I really appreciate all of the interaction. I love seeing everyone's reactions to things. And it's just wonderful to gather and to share insights into this topic. So I hope this was supportive for you, no matter where you are on your journey. Please, again, be in touch. My email is there. Those links are there. We'll send out another follow-up email. And a huge thank you to Sam and to Jay for being with us today and sharing all of your rich insights.
Thank you,
Thank you
everyone.
all so much. Yes, wonderful to be
Thank
here.
you. Wonderful. Have a great rest of your day, everyone.